Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I want to talk about trigger points that I use the most for solving knee pain. As you know from previous episodes, I work on restoring the joint function without major concern about actually trying to treat the joint that is causing pain, that it has pain. There might be arthritis, there might be previous injury of soft tissue. As long as the person has had a discussion with a doctor and ruled out any major issue like a ligamentous injury, we are going to focus on restoring joint mobility. And as you know from my previous episode about treating knee pain, I like to focus on the hips, the hamstrings, the quads, and the gracilis mostly. I'm looking at the pes anserine muscles for medial knee pain with sartorius, gracilis, and semitendinosus. I am going to look at patellar tracking issues caused by the quads and the IT band. So, of course, we're going to look at the TFL glute med, sometimes piriformis. And we are going to look at, mostly we're going to work on the quads. On all knee pain patients, I will end up treating the quads. So, what happens when you've done all of that and your patient bends her knee and still has knee pain? Lateral knee pain especially, or maybe medial knee pain. What do you do? So if you are the local pain focused medical practitioner, like medical doctor, knee surgeon, you're going to say, well, you've got, arthritis, degradation of the soft tissue, you're bone on bone. Of course you have pain. Next patient, pay at the desk. If you are a spinal segmental acupuncturist and you are mostly thinking about spinal segments, motor points, and the local area that's in pain, maybe you're going to focus more on the L4 and 5, and you're going to try to neuromodulate that knee pain by sticking needles into the joint, usually under the patella. And if you are a functional acupuncturist who's going to look at the joint function and consider that there's still pain because there's still joint dysfunction, movement dysfunction, muscle fiber dysfunction, you're going to do what I do. And you're going to start palpating the patient to find the muscle fiber dysfunction that is perpetuating pain because of joint dysfunction. So I'm going to tell you about two patients of mine. One of them is about 80, and she came to me with lateral knee pain the week before she was leaving for Paris, and she was going to be walking all over the place. And she said, I hope you can help me. I'm in so much knee pain. And it was lateral knee pain. So, of course, I checked the hips. I treated the quads. She still had lateral knee pain at the end of motor point treatment for all the usual suspects. She still had lateral knee pain. And she pointed to where it was. And it really seemed to be like right above the patella, a little less vastus, a little less IT band, going down to like the tibia, and a little more right along the vastus lateralis above the kneecap and even up higher. So I started to palpate and I found the painful long vastus lateralis trigger point that was causing the pain. And it was really, it's deep. It's really at the like the bone level. So if you're just lightly palpating the vastus lateralis, you might miss it. You're going to have to dig in deep to find at the bone level the painful long trigger point. And for her, it was probably as long as the width of my hand, maybe 4 or 5 inches, along the lateral bone, a little bit anterior or just deep to the front part of the IT band. So, long story short, I released it, and she thanked me when she came back from Paris. She said, "Oh, I can't even thank you enough. I've had such a great time in Paris with no pain. I was able to walk up and down the hills. They went to Montmartre, and they had a great time. And she was so happy that she didn't have to go to Paris and be nursing her knee pain." Next patient I saw recently with medial knee pain. And it's a regular patient of mine, so I know all her history. Same with the other one. You know, it helps when you've been treating them for something, so you kind of know what their imbalances are, what their movement pattern problems are going to be. But this was kind of new to this patient. Mostly she's had like a lateral hip issue, greater trochanteric pain, that sort of thing. And but this was a medial knee issue, and it seemed like her pain was not quite pes anserine. It didn't seem to be as far down near the inner joint of the knee. It seemed a little more like vastus medialis sort of pain. Well, I treated I palpated the gracilis was definitely tender, but that can be on many people. She didn't, I said, "Do you have any hamstring issues?" She said, "No." I pressed on semitendinous. She said, "Oh, that is sore." So I thought, okay, it's pes anserine. I treated hamstrings. I treated gracilis and the quads, and with electric stim, like 10 minutes, loosen it up. And when I took the needles out, I said, "Let's test." So she bends her knee and she still has medial knee pain. So what do? Do you just say, well, shrug it off? She's in her 60s, so it's just arthritis, tough to be you. Do you say, well, let me stick some needles in the kneecap, maybe it's your back? And like I said, if you are aware of the high percentage of people for whom joint pain comes from dysfunctional movement, then you will stick to your guns and find the problem in the muscle fibers. So I palpated deep on the vastus medialis. That's sometimes called VMO, vastus medialis obliquus. It's like a teardrop muscle. And the typical trigger point there is sort of at an oblique angle. It will start close to the upper part of the patella, maybe a finger width or two above the medial upper patella area. And it will go at an angle toward where the gracilis is, towards the medial part of the inner thigh area. So you dig in and you feel if there is a painful band in there or two. And for this patient, I could palpate something really firm in there, but she didn't think it hurt until I had her bend her knee. And then we both agreed that yes, it was the source of the pain. So I had her bend her knee. When she felt the pain, I said, put your finger on it. So then I put my finger where her finger was, and I feel the tight band. And then when she straightens her leg, it doesn't feel so painful. So I said, okay, this is what it is. It is this trigger point. You only feel it when it's stretched. So I released the trigger point and then had her test again. She still felt some pain. I found another band in the Vimo, a little more medial to where I was, released it. And then when she bent her knee, it felt different. She said, it still has some pain, but it's not like the sharp pain. I said, is it like a bruise or a sore muscle? She said, yeah, and it's pretty sore. I said, okay, I think you're going to be fine. I put some anti-inflammatory hemp cream that I have. And when she was walking, she could feel the improvement. And I think, and she's on her way tonight to Florida. So it was like a last minute treatment, like right before going away for a week. So I'm pretty certain she's going to be way better in a day. I told her, listen, it's going to be sore for the next hour, probably much better tonight. But the more you massage it to clear inflammation, the faster it's going to get better. So, you might have a day or two of it not being perfect. It's going to be a little sore, maybe not so great. But the more you massage it, the better it's going to be. Just clear that inflammation, massage toward the heart, just get that inflammation out. I think she can be fine. But so many times people have knee pain caused by trigger points, and if you're just throwing your hands up because they still have pain after your treatment with motor points, then you're missing something. You don't blame the patient's weight. Don't go with the easy, oh well, you have arthritis. All the usual suspects that get blamed. Yeah, they probably do have some arthritis, but that doesn't mean they have to be in sharp knee pain. You can release the muscles, let the joint function properly, and they have no pain. So that's really kind of a difference in how I see things and how I treat. Partially it comes from my unwillingness to fail. And part of it comes from me studying enough of Yonda and Janet Travell to know how really important it is to look for dysfunction in the muscles as opposed to blaming the joint. If you blame the joint, you've kind of given up, and you've given the patient, like you're basically giving them the same solutions that they would have had they never seen you, which is going to be anti-inflammatories, rest, lose weight, do physical therapy, etc. If you realize how much the pain is coming from dysfunctional movement and muscle fiber dysfunction, you are more likely to give them a much better, faster result than if you stick with the status quo. So, yes, your patient might be overweight. Yes, they might be over 60 and have arthritis that's been proven with imaging. That is no reason to just throw your hands in the air and say, oh, well, the best we can do is some neuromodulation with electric stim in the joint, and let's hide the pain. Or maybe let me fall back on my distal treatment and I'll treat your opposite elbow with needles until you have no pain when you move your knee. That is just temporary. It is not correcting the dysfunction. And while it might be nice to see that patient 10, 20 more times, the goal for me is to get them out of pain so that they don't need to see me. They're going to come back when they need something, but hopefully it's not that same thing that we were just treating. So I'm going to look at functional movement and correct the movement of the joint by looking for muscle imbalances, and that includes muscle fiber dysfunction trigger points. And okay, so those are my go-tos. Do I end up doing trigger points on rectus femoris? absolutely. Not as often. If you're going to find rectus femoris trigger points, they're usually higher up in the leg, closer to where the fibers are doing more hip flexion than knee extension. But when they're short, when the rectus femoris is short, you are going to get that patellar knee pain, especially when the knee is bent, like when they're sitting for a long time. But you're going to find most of the contraction is going to be the upper quad, where it is more of a hip flexor. Probably the upper third of the rectus femoris is where you're going to find the juicy, tight bands that are causing restriction. Sometimes I have to needle that, so I'll do stim on it until I'm not getting enough results, and then I have to start dry needling the upper rectus femoris for somebody where they've had like a knee surgery and they can't get past 90 degrees of flexion. So, that's going to be joint fiber dysfunction. You can't blame the joint. It's like not even like a human thing. It's a mechanical joint that is meant to be functional. So you can't blame the joint anymore. You can't blame the patient. And you can't blame L4-5. You got to look for the muscle fiber dysfunction that is restricting the knee flexion. So in that case, going to be the upper third of the quadricep, the rectus femoris area, where you're going to get the best release that's going to improve the joint function and range of motion. Okay, so I'm going to leave it at that. And hopefully that helps somebody out there who has been throwing up their hands when their patient still has pain after a treatment for knee pain. So it is the 30th of December. So have a very happy new year. And I will talk to you next year.